Good morning, everybody.
Good morning.
Hey, my name is Xiaobu, one of the first-year cardiology fellows here at VCU. Thank you for attending our grad round lecture. I'm pleased to introduce to you our speaker, Dr. Richard Shepard. Dr. Shepard is an associate professor of medicine, cardiology, and EP. He went to Harvard University undergraduate and UAB Medical School in Birmingham, Alabama. He trained in cardiology at Washington University Barnes Hospital in St. Louis and did EP training at VCU. His primary interest is clinical interventional EP with ablations, devices, LA appendage closure, and lead extractions. He was part of the original trial for respicardial remit phrenic nerve stimulation for central sleep apnea treatment and continues to implant this device. VCU has been the only center in Virginia implanting this device. We are grateful for Dr. Shepard's expertise on this topic and look forward to learning from him. At the end of the lecture, we'll leave time for questions. Please submit questions via the chat function on Zoom as they arise during the talk. We are pleased to offer both CME and MOC credit for our Grand Rounds conference series. To claim credit for today's session, text the code shown at the beginning and end of this presentation to 804-625-4041. For questions or log into your Cloud CME account, please visit vcu.cloud-cme.com or contact Shannon Winston. I will now turn it over to Dr. Shepard.
Good morning. It's Tech Shepard. Hopefully my screen is sharing okay. Today I'm going to talk about cardiology and central sleep apnea. And I'll explain why I'm involved with central sleep apnea a little bit. Okay. I have no disclosures. I do implant the respicardia system, which we'll be talking about some, and participated in original trials. And very important, I am not a sleep doctor. So I'm not a world expert in sleep, but I know about the procedure. Okay, so first slide is, what the heck is this? When we did our first procedure, we showed this to the radiologist, like, where do these things go? There's a funny device here, and the leads don't go to the heart. We're like, what is this thing? Okay. So the first Remedy phrenic nerve stimulator implanted VCU was done in 2014 as part of the pivotal trial. There were maybe 20 implanters in the country chosen for expertise in putting in by the ICDs because it was a similar type procedure. So what we'll do for this procedure is we get a catheter starting over in the right axillary, come across to the left brachiocephalic, do a venogram in the brachiocephalic, and then we'll find the pericardiophrenik vein, which I hadn't heard of until I started doing this. And it comes down here and goes along where the phrenic nerve is. Then put a wire down the pericardiophrenik vein. You see it comes down right along the left heart border. Get a sheath in there, and then through this sheath, we can put a lead down the pericardiophrenik vein. And then this lead goes down the pericardiophrenik vein. Here it is in AP, and here it is in lateral. We'll go over this in great detail in a little bit. And then once you have a lead, this is the lead in the pericardiophrenik vein here. It can be used to stimulate the diaphragm. When you turn it on, boom, goes the diaphragm. This is just for testing. With the actual device, it's a slow, long, steady breath. So that's just a teaser of what we're going to end up with. Okay, so what I'm going to talk about today is sleep apnea with a brief discussion of obstructive sleep apnea, cardiovascular problems with central sleep apnea, and then central sleep apnea treatment. So sleep apnea has a lot of cardiovascular effects. With hypoxia and sympathetic activity surges, you can get hypertension, increased preload, increased afterload, promotes myocardial ischemia and arrhythmias, and then enhances oxidative stress with endothelial dysfunction, inflammation, and also activates the neurohumoral system with progression of diseases. So how do you look for sleep apnea? There's something called the apnea-hypoxia index. Apnea is when you don't breathe, and hypopnea is when you have slowed, shallow breathing that occurs in 10-second or longer episodes repeatedly during sleep. And then with the American Academy of Sleep Medicine, mild sleep apnea would be 5 to 15 events per hour, moderate 15 to 30, and severe greater than 30 apnea-hypopnea events per hour on a sleep study. So who has obstructive sleep apnea? Patients that have sleepiness, non-restorative sleep, fatigue, insomnia, wake with breath holding, gasping, and choking. Your bed partner observes snoring, breathing interruptions in sleep. And then what all our patients have: hypertension, mood disorder, cognitive dysfunction, coronary artery disease, strokes, heart failure, AFib, very common in sleep apnea, diabetes. And then on the sleep study, 5 or more predominantly obstructive respiratory events for obstructive sleep apnea per hour. Okay. High risk for obstructive sleep apnea, who should we evaluate? Anybody obese, patients with heart failure, patients with AFib. In our practice, treating sleep apnea is markedly good for decreasing AFib episodes. Patients with hypertension, diabetes, nocturnal dysrhythmias, stroke, pulmonary hypertension, all these cause sleep apnea. And then look in high-risk driving populations or preoperative for bariatric surgery. Okay. So obstructive sleep apnea, we look at the apnea-hypopnea index, the respiratory disturbance index, and the respiratory event index. Basically, it's just number of apneas. We use that the most. Less than 5 is normal, 5 to 14 mild, 15 to 29 moderate, and greater than 30 severe, as we mentioned. Okay. So what's the treatment for obstructive sleep apnea based on severity? For mild, positional therapy, there's oral appliances, and then uvulopalasty surgery. Secondary treatment for mild would be CPAP, and then for everybody, it's weight loss and positional therapy. For moderate obstructive sleep apnea, CPAP is #1 treatment, followed by oral appliances or surgery, and weight loss again. And then for severe, same thing, and then another surgery we'll talk about in a second. This is still all obstructive. So CPAP is great for obstructive sleep apnea. The problem is it only works when you use it, and up to 80% of patients have been non-adherent in studies, and that's why many surgical procedures are being evaluated for obstructive sleep apnea. So the Inspire sleep device has been shown to be great for obstructive sleep apnea. It's an operative technique for upper airway stimulation with an implantable device. So this is not what I do. This is what ENT surgeons do. This is the Inspire device. It's got like a pacemaker pulse generator type device, a sensing lead, and a stimulation lead. This is all for obstructive sleep apnea. And the Inspire device is implanted in the chest here with a sensing lead going down between the ribs, and then the stimulation lead goes up to the hypoglossal nerve. The implantable generator delivers electric pulses through the stimulation to the hypoglossal nerve, synchronous with respiratory cycles. So here's where they operate here. They'll put a cuff electrode along the hypoglossal nerve and then attach a stabilizing electrode on the digastric muscle with and then a relief here, so when it pulls on it, it doesn't pull it out. What this does when it stimulates, it pushes the tongue forward to prevent obstruction. So this is the Inspire device. Stimulation pulses start when the patient begins to inhale. The sensor senses that, because in obstructive sleep apnea, you try to inhale, and then stops when the patient begins to exhale. The timing of synchronization can be adjusted. And it had great results for obstructive sleep apnea. This is 2014 New England Journal. This is a baseline 30 apnea-hypoxia events. When you turn on Inspire, it went down to 12. If you turn off the Inspire, you go back to where you were. If you leave it on, you stay good. Same thing for oxygen desaturation, markedly decreased with Inspire. If you turn Inspire off, oxygen saturation goes back up again. The Inspire device is great for patients who can't tolerate CPAP, and it's implanted a lot here. And if anybody wants one, talk to Dr. Ryan Nord. He's in otolaryngology. And he's like a world expert in implanting the Inspire device. So just a plug for our obstructive sleep apnea patients, along with CPAP. All right. Okay, now we're going to talk about central sleep apnea and cardiovascular patient population. So what is central sleep apnea? Central sleep apnea results from intermittent neural drive to breathe. Patient with comorbidities such as heart failure, AFib, and renal disease are at markedly increased risk for central sleep apnea. So if you look at their chest movement, their abdominal movement, and their breathing, they just stop breathing. There's no attempt at respiration. They'll have crescendo up and down when they do try to breathe. So it's don't breathe and breathe really hard. No attempt, no diaphragmatic motion at all. And then they get drops in oxygen saturation and restart the cycle. It's sort of out of phase, the oxygen saturation, because it catches back up. Okay, how do we breathe? Everybody learned in med school, I hope, C3, 4, 5 keeps the diaphragm alive. So the phrenic nerve, you have two of them, right and left, comes out from C3, 4, 5. And on the right side, it comes down along the right brachiocephalic vein and the superior vena cava, and then along the right atrium. Also back here is the right superior pulmonary vein. On the left side, the phrenic nerve comes down and then parallels the left pericardiophrenik vein and arteries, and then down along the left heart border. Everyone in electrophysiology is very familiar with the phrenic nerve because it's always in our way. On the right side, when you're doing an AFib ablation, it's right near the right pulmonary veins when you're on the lateral, the septal portion of them. And if you burn there, you can paralyze the diaphragm. So always test for that. If we're ablating along the lateral right atrial border, for some atrial tachycardias or sinus node, you can also paralyze this. So we're very attuned to where it is. And on the left side, the phrenic nerve is right along where we like to put our epicardial biventricular pacing leads. You can get phrenic stimulation. So EPs are familiar with the phrenic nerve, but what it's for is for breathing. You don't want to knock it out. So for the respicardia device, what we want to do is stimulate this phrenic nerve to start breathing, which we can do from here or from here. Okay, so what's the pathophysiology of central sleep apnea? During sleep, respiration is regulated by the brain. It tries to maintain a constant blood CO2 level. To keep the CO2 regulated, the brain sends signals to the diaphragm through the phrenic nerve, control the breathing pattern when you're unconscious. With central sleep apnea, the brain develops a respiratory arrhythmia that manifests as an oscillating pattern between hyperventilation and apnea. So you have CO2 sensors in the aorta, nerve signals go up. When CO2 increases, pH decreases in the blood and stimulate the center, down the phrenic nerve to the diaphragm. Okay, so the difference between obstructive and central sleep apnea is evidence in sleep studies. And obstructive sleep apnea, when you have obstruction, the abdomen moves as the breath is attempted, but airflow is blocked or reduced from obstruction, resulting in oxygen desaturation. Oops, let me go back one, sorry. And then in central sleep apnea, the abdomen doesn't move at all. There's just no attempt at breathing. There's limited or no airflow due to a lack of breathing, resulting in oxygen desaturation also. Desat here when you don't breathe. Okay, so they're completely different mechanisms. Okay, so most patients with central sleep apnea also have concomitant cardiovascular conditions. Heart failure, stroke, idiopathic heart causes of sleep apnea, AFib, and then heart failure and AFib. So central sleep apnea occurs in 30 to 50% of patients with heart failure with reduced ejection fractions, and about 18 to 30% of heart failure with preserved ejection fraction. 70% of central sleep apnea patients have heart failure and a reduced LV ejection fraction. And then AFib, central sleep apnea occurs in 10 to 30% of patients with AFib, and about 20% of central sleep apnea patients have AFib. So they go together. And then of the heart failure population, this is back from a 2011 study, About a third have central sleep apnea, a third have obstructive sleep apnea, and a third have no sleep apnea breathing disorder. So what symptoms do they get with central sleep apnea? Fatigue, because they have a low cardiac index, medication side effects, depression, hospitalizations, nocturia, frequent awakening. The apneas can be noted. The patients usually don't snore, and they may not even know they have sleep apnea. Okay. So untreated central sleep apnea can cause life-altering levels of fatigue, as well as increased health risk for heart failure and AFib. So loss of neural drive, apnea and hypopnea. From this, you get a hypoxia and arousals. The arousals have surges of adrenaline. From that, you get increased ischemia and inflammation, increased sympathetic drive. Fatigue, sleepiness, cognitive impairment, depression, memory deficits. And then untreated central sleep apnea increases risk for 2 times more likely to have heart failure, readmissions, twice the mortality rate in heart failure patients, high rate of AFib. So here's the basic mechanism of what central sleep apnea does for the heart. You get apnea-induced hypoxia and reoxygenation, which leads to endothelial dysfunction, vasoconstriction with platelet aggregation, and thrombosis. Same thing, you get smooth muscle proliferation and LV hypertrophy. You get inflammation with altered cardiac contractility and adverse cardiac remodeling. And then the arousal-induced norepinephrine release can cause myocyte hypertrophy or apoptosis, remodeling, increased arrhythmias, which we see sodium retention, and the renal angiotensin activation. All this leads to blood pressure problems, oxygen demand, and plaque ruptures. So lots of problems. Apnea and hyperapnea, you get low oxygen and surges of adrenaline. This is from European Heart Journal. Sleep disorder breathing is a predictor of mortality in heart failure patients. No sleep apnea versus obstructive or central sleep apnea, marked increase in mortality with the central sleep apnea, up to a 2-fold increase in risk of death. This is over about 36 months here for untreated. Risk of heart failure readmissions, no sleep disorder breathing, no readmissions, and then marked increased readmissions if you have sleep disorder breathing. 50% of heart failure patients with central sleep apnea were admitted to the hospital at 6 months, and over 25% of heart failure patients with central sleep apnea had 2 or more hospital readmissions within 6 months. Hazard ratio. Okay, so there's been limited treatment options for central sleep apnea. CPAP works for some people. Most common treatment with clinical trials, some improvement, but usually not, and some increased mortality if you have a low ejection fraction. There's adaptive servoventilation. And if you have a low EF, your mortality was higher. There's a black box warning for that. That's where it kind of senses if you need to breathe or not and does it automatically. Oxygen therapy can help. And then medications haven't had any benefit. Excuse me. Positive airway pressure, frequently described. Patients frequently don't wear them, don't tolerate it, and doesn't work if you have a low EF. It's great for obstructive central sleep apnea. Okay. So this was positive airway pressure, no benefit in a trial. It's from New England Journal of Medicine, 2005 and 2015. And then with the SERV-HS, the servo trial, mortality was actually increased with the servo if you had a low EF less than 45. Okay, so that brings us to the phrenic nerve stimulator. Transvenous phrenic nerve stimulation with the Remedy system. It's called Remedy. It's made by Respicardia. So it's a fully implantable system with indication to treat moderate to severe central sleep apnea in adults, FDA approved in 2017 after the trials. It stabilizes breathing by activating the diaphragm to generate negative pressure in the chest, similar to normal breathing. Turns on at night, you program it this way, ensuring nightly compliance and adherence over time, put in by cardiac EP doctors. And then the stimulation lead can go down the left pericardiophrenic vein or can go into the SVC here, where the right phrenic nerve is. There can also be a sensing lead that goes down the azygos vein. Fortunately, in the new devices, we don't need to put in the sensing lead because it took a lot of extra time. So here's just a schematic of one, similar to what I showed you before. This is a Respicardia one from their files, but stimulation lead comes across the brachiocephalic into the other brachiocephalic and then down the pericardiophrenic vein, which runs right along the pericardiophrenic nerve. And this is sensing lead down the azygos, which goes back behind the heart. Okay, so how's the system work? Therapy is delivered. When you program nighttime, we ask patients when they go to sleep, you actually go into a sleep center after you have it implanted and get it adjusted. But it turns on when they want to go to bed. They have to be reclined at a certain angle. They have to be not moving. The reason is you don't want this thing activating if you're wide awake. It's not going to feel comfortable. It just tells you to start breathing. So therapy is paused if you sit up or if you start rolling around. Then it resumes a few minutes after the patient returns to the reclined position and is once again still. So here's some data from sleep studies with therapy on and therapy off. This is with therapy off. Oxygen saturation goes up and down. Breathing stops, starts and stops. Airflow starts and stops. Therapy on, it's just normalized across nice and smooth. Good result from the remedy system. So programming, what do we do with this after we put it in? When you first put it in, you don't do anything. It just sits there for a month. Patients are like, how come it's not turned on? We have to let it settle in. So 1 month of just waiting, then you get it titrated with the sleep studies. They'll adjust it so that it benefits you just right. You adjust the intensity of the output based on capture thresholds and various other things, time your sleep cycle, and then long-term follow-up, you come back for sleep studies every so often and check it. And then you come back to me when the battery runs out. So there were multiple trials. This is what it looks like. This proof of concept, and then the pilot study. The pivotal trial is what we participated in until it was approved. Large randomized trial, and it showed significant improvement. So here's from the pivotal trial. It was in Lancet in 2016. Transvenous neurostimulation significantly reduced severity of central sleep apnea, including improvements in sleep metrics, and was a positive trial. So I'll show some of the data. Endpoints, comparison of the proportion of subjects with greater than 50% reduction in apnea-hypopnea index between treatment and controls, primary safety, freedom from adverse events, and then secondary central apnea index, apnea index, arousal, rapid eye movement, oxygen desat, and the Epworth sleepiness scale, which I can show at the end if anybody wants to know what that is. So there was basically improvement in everything. P-value less than 0.001, reduction in apnea-hypopnea events, quality of life improved, and safety was okay. So here's reduction in sleep apnea events. This is the central sleep apnea went from like 30 down to 0.2. It was always, people had concomitant other things, obstructive and mixed, but marked decrease, 67% decrease from in-lab sleep study follow-up over all the patients. Residual events were from obstructive or incomplete ventilator capture from the device. So the remedy system treatment resulted in significant improvement in symptoms and quality of life after 6 months. Treatment, Epworth sleepiness scale improved, global assessment improved, and then they were willing to repeat the procedure. Pretty safe. Freedom from serious adverse events was low. No long-term sequelae, no deaths, 97% implant success, and half of them already had a cardiac device in. Sometimes that can get in the way a little bit, but not too bad, because a lot of them have defibrillators because they have heart failure. Okay. So here's over time. Apnea, hypopnea goes down at 1 year, 2 years, 3 years, still down at 5 years, paired at 5 years. The central sleep apnea events were still markedly decreased. But here you need a generator change. Okay. Just multiple studies show difference with decreased apnea events. Favors phrenic nerve stimulation. Okay. So all trials. Okay, so what does this do? In heart failure, central sleep apnea can accelerate cardiac disease progression, reciprocal interaction between central sleep apnea and heart failure. They kind of feed off each other. Central sleep apnea, you have the apnea, hypopnea, hypoxia, arousal, as we mentioned this earlier, ischemia, inflammation, increased sympathetic drive, and then pump stress, adverse events, decreased left ventricular function, which feeds back into central sleep apnea. So here's some sub-studies, phrenic nerve stimulation to treat patients with central sleep apnea and heart failure with European spelling. This was from the European Society of Cardiology. So change in quality of life in pooled heart failure population with active therapy at 6 and 12 months. The Epworth Sleepiness Scale was better in the heart failure patients. Minnesota Living Heart Failure Score was better in the sleep apnea patients. And then Harvard data, the ejection fraction minimally improved about 3 points, 31 to 34. And systolic volume improved, and diastolic volume also improved with phrenic nerve stimulation. All heart failure patients. Just kind of re-go on how it works. The power we use, amplitude 0.1 milliamps up to 10, 60 microseconds to 300 microsecond pulse width, and 10 to 40 hertz. It gives a slow, gentle rise. Okay. This is back to the pivotal trial, which we participated in. Enroll the patients if they have a positive sleep study for central. Roll in, endpoint, and on from there, and then the controls. Demographics were all similar for all patients. The majority of treated patients demonstrated a decrease in apnea at 6 months and 12 months. A few got worse, but the vast majority improved. At 12 months, 91% demonstrated decrease in the number of apnea and hypopnea events. Marked improvement in how they felt also, quality of life. And this is the heart failure cohort. Global assessment, markedly better with all of these endpoints, especially the Epworth Sleepiness Scale and the Minnesota Living with Heart Failure, improved with the device. Okay. Ejection fraction, minimal improvement in the heart failure patients. Rehospitalization, marked improvement to first hospitalization. And the mortality, not much. Okay. Back to the system just for a minute. Stimulation down the pericardiophrenatic vein. And again, this is down the azygos vein. I'll show some pictures of our studies at the end. This is if you have to put in, this lead is just a straight lead. It's down a tiny little vein. This lead, if you have to go to the right side, is in the superior vena cava. It's a big, huge coiled lead. It's got 6 different poles on it. And you just kind of twist it until you get up against the nerve and you pick the poles that are there. It's much more likely to move and not as stable because it's in the superior vena cava and the brachiocephalic. You can see the phrenic runs all the way along this whole area. It's going to show a few of our cases. So there's a lot of veins when you come off the brachiocephalic. The internal jugular comes off more lateral. It comes off down here. Then there's the pericardiophrenic vein. There's also the internal thoracic vein. You can get into one and not know which one you're in. And LAO, the pericardiophrenic vein is going to run along the heart border. The internal thoracic vein will run down the front of the chest. Okay. So these are all studies we did here. You get this kind of little inner catheter. You pull back and you'll just squirt, squirt, squirt till you find the pericardiophrenic vein. Then you get a wire down it. It goes all the way down to the diaphragm. You get it back up, wrap it around, and come back up the SVC sometimes. Then once you get down the pericardiophrenic, you put down the lead, 4 poles, the top poles up there. And this right there is, we'll play again. When we're testing it, well, the patient's just breathing. We have them awake so they can feel it. And then there's the stimulation. On both sides, you can get extra phrenic stimulation. The nerve does some other things. So you want to make sure it doesn't cause any stimulation up in the throat or the neck, in which case we have to move it a little bit. And we'll look for an area with the strongest stimulation. A lot of times you'll have it in a good spot and it just doesn't stimulate the diaphragm because it's not close enough to the phrenic nerve. And then you have to reposition or move it. I'll show it one more time. I always like seeing it when it goes boom. And then we do it at the, look for the lowest possible threshold. We'll move till we get a low threshold. It may move a little bit once they get up and move around. So we want a strong response. So this is the final site of one respiratory lead. This is the heart right here. So usually we have it up a little bit up here. You can't get it all the way down by the heart, but you don't want to stimulate that. And if it comes too far up here, you get more of the extra cardiac stimulation. I mean, extra phrenic stimulation, sorry. Still thinking EP. Unfortunately, a lot of people have atretic pericardiophrenic veins. We'll get in there and squirt and you don't see anything, or you'll see a lot, just a plethora of little things. And that's when we go over to put it down the superior vena cava and right brachiocephalic. The lead comes in here, and we have the 6 poles here, and we just twist it until we find a good spot where we can stimulate the phrenic, which is running around like that. This one's a little harder to be stable. This is an example of why we have phrenic stimulation. When we put in our bive pacing leads, most of you have probably seen patients come in and their diaphragms jump in when they have a biventricular ICD or pacemaker in. This is a biventricular, this patient has a biventricular pacemaker. This is the pacemaker wire. It comes into the coronary sinus, wraps around and down a LV vein. And this is a wire down the pericardiophrenic vein when I'm putting in the device. So you can see they run right beside each other. So if you stop. So if you're pacing here, you might just stimulate the phrenic nerve, and that's why we see that so often with our bive devices, and that's why now all the bive devices leads have 4 poles. So you choose the one that doesn't stimulate the phrenic nerve. Okay. Here's an example. This patient has a pacemaker in. This is not the remedy device. It's just a pacemaker over here. This is an atretic pericardiophrenic vein. We just see this all the time. There's just spiders. I got a wire down here, but the dye won't even go down there. It's just so tiny and atretic. Squirt some dye. And sometimes that'll have collaterals over to the thoracic vein also. Okay. So that's when we're going to put in the other side. This is just another phrenic stim test. Diaphragm going. And this is the patient when we moved the lead into the superior vena cava. You can see the top of the lead here. I'll show a picture in a second with the other pacing wires coming down. So here's a lead of one we did where it's coiled around in the superior vena cava with the phrenic coming down here. We started stimulation. This is the actual device. It's always put it on the right side, or 99%. It has to be straight up and down like this when you put it in, or it won't work right. If you have it crooked, it's just because the angles when they lay down to sleep, you want it just right for them. So there's just some technical details in that. Another picture of a phrenic nerve with there's lots of little collaterals there. See that all the time. And but still get a lead down. Okay. This is a venogram of the azygos vein. Fortunately, we don't have to go down here very often anymore. Here's a lead. The lead is down the pericardiophrenik, and the wire keeps on going down. So the azygos vein comes off the superior vena cava, and then it goes posterior down behind the heart. If you look lateral, it's way posterior. And it has all these tiny little branches down it. So to get into it, you just come down the superior vena cava, and you'll twist and turn. It kind of comes up at a funny angle. Then you get a wire down there. Rarely we'll still have to go down there if we don't have good sensing, but usually you don't have to go down the azygos. And the reason we put a sensing lead down there is it was near the diaphragm, so you could see if the diaphragm was moving or not. You bring it down here, come off in little branches down here when we were using the azygos vein. So here's an example with a device in. This device was turned sideways. I'll fix that later. Pericardiophrenik over here, azygos down here, right above the diaphragm there, which we use for that. I have a lot more slides in a minute, but I just wanted to show a couple of these. Picture of the whole system here. Okay, so before the excess slides, that's the basic of the talk. I kind of rushed a little bit. Central sleep apnea contributes to harmful progression cycle of hypoxia, arousal, and sympathetic activation. Few treatments for central apnea and little randomized data up until now, but the phrenic nerve stimulation offers safe and effective therapeutic options for treatment of central sleep apnea with improvements of both sleep apnea and quality of life. So to get one of these devices, you need a sleep study. There's several centers in town that do them. We work with them. There's long waits at all sleep centers to get in. Right now, we're the only people in Virginia doing this, so we get them from around different places. The volume's been increasing recently, just more people are aware of it. It's still a tiny percent of my practice, maybe 1%. But I see people in most clinics now who are setting up for a device. And we're certainly doing them here and screen our heart failure patients and our other heart patients. Okay. Now I'll be happy to answer any questions, and I have a lot of backup slides if there's any more questions, like on sleepy scale and that type of thing. Okay.
Thank you, Dr. Shepard, for this excellent talk. I do have a question. Is a lot of this central sleep patients has comorbidities of arrhythmia like AFib or non-systemic VT, and almost half of the patient's population have already had a cardiac device. I wonder if there is any trial or study to just look at the outcome in terms of arrhythmia.
They decrease, but there's been not many randomized trials. Those were more with the heart failure. We've certainly seen that in the AFib population with treatment for obstructive sleep apnea, which has the same mechanisms of failure. AFib markedly decreases with that. And also, post-AFib ablation, your chance of recurrence of AFib is directly related to losing weight if you're obese, which goes along with treating your central sleep apnea. So we've seen it more with that. Don't have a trial with central sleep apnea that I'm aware of on decreasing arrhythmias, but the heart failure stuff I show, is clearly documented now. That may be something important for the future. But as I said, every patient who gets an AFib ablation now, we strongly, we'll get them into weight loss programs or anything else, because that markedly decreases recurrence. It's like the single best predictor of decreasing recurrent AFib is if you lose weight or if you're not obese.
Thank you, Dr. Shepard. And do you think it is worse just to look at to interrogate the patient's device to see if there's a decrease in arrhythmia in this treatment group.
Yeah, I think that's great. It'd be easy to do in patients who already have pacemakers in because all their arrhythmias are documented. So, it might be easy to look before and after on patients who have devices already. We get both. About half have devices already. And then they vary, in etiology also, heart failure etiology, opiates and different things. But that should be pretty straightforward to do with events monitors. Depends on how the incident is ahead of time. That's a great idea. Thank you.
Thank you. And we have a guest that was asking, Dr. Shepard, thank you for taking time to give us a succinct update. How do you see the plethora device being simplified down to the ruled CHF patients such as CRTD, CCM, central sleep apnea, and pressure monitoring device such as CardioMEMS?
Wait a minute, I don't quite understand the question. How do I see how it fits in with that? I'm not sure I understand the question, but it's easy to put in with other devices. Usually defibrillators are on the left side, and this goes in on the right side. It can be a little bit in the way, but it'll go in to patients who have heart failure, as long as they can tolerate, laying down. And the other devices are generally not in the way unless they have multiple leads that we don't want to occlude any further. And sometimes the left pericardiophrenic vein can be occluded. If patients have left-sided devices, then we'd have to go down the superior vena cava. Prefer not to put things in the superior vena cava just because they might get stuck and be in the way, cause obstruction down the road. I'm not sure if I answered the question because I didn't quite understand it. Anything else?
Kirk, I have a question.
Yeah.
So, we try to send patients to the sleep clinic not infrequently, but there's a very, very long lag time.
Oh, yeah.
Whereas we can order sleep studies and they get done pretty quickly. So if we order sleep studies on our patients and they come back with central sleep apnea, is there a cutoff at which we should look at and say, okay, this is reasonable for me to refer to Dr. Shepard for consideration, or do they have to go through sleep clinic first?
Excellent question. That's why I deal with a lot of sleep centers outside of VCU. They're sometimes a little faster turnaround because they refer them themselves. But they will have to be associated with a sleep center because that's where the titration is done and the long-term follow-up. So we can certainly initiate that, but they need to at least have some contact with a sleep doctor before I want to do it, because they're the ones who will titrate it with follow-up sleep studies. And that's a nationwide issue, as the sleep study centers are all just way overbooked. I mean, it's 9 and 10 month waits to get in. So I've worked with them out at the Bon Secours and the big pulmonary group. I forget what they're called. Quite a bit. The one at VCU has a long wait. I need to have better contact with them, actually. And then Dr. Nord, who does the Inspire device, also, sometimes they'll be sent to him and they'll say, oh, that's all central sleep apnea, and he'll send them over. But the answer is I much prefer them to be associated with a sleep center, not just the result. And that is one of our main issues right now.
Great, thank you.
And I have a subsequent question. Dr. Shepard, if you see one device serving more than one purpose to limit number of devices needed.
Yeah, right now this device is only for central sleep apnea. There's no pacemaker or anything else that could go around with it, multi-purpose device. I don't know if they'd ever do that. Zoll bought out the Respicardia. They don't do, other devices really, except for defibrillator externals. The lead's going completely different places. I don't see that right now. It's possible, but a lot of people end up with a device on the right and the left with their defibrillator on one side and their sleep apnea device on the other. Possibly something down the road. If you just get a single lead, you could plug it in. It'd be a complex device to do that. But AI is coming, so they could probably do it. Okay. Any other questions? Okay. There's just a couple of things on what the Epworth sleepiness scale is. what they ask you to do about, when you fall asleep. And then the other major test was the stop bang sleep apnea questionnaire. This is how we screen, and this can be done in heart failure clinics or just general cardiology clinics, to see if you need to send one for a sleep study. And all right, let me go back to the credits there. Does anybody else have a question or concern? Follow it. But to go back to Barbara, Dr. Lawson said the biggest rate limitation right now is the sleep study centers, just because they're so booked up. But this therapy is proven, it works, and it's very, very helpful for people who do have central sleep apnea. All right. Any other concerns or questions?